Thank you very much for your coming. We start the educational session number 4, entitled From Bench to Bedside. I would like to do a real educational session, but in this scenario is not easy. Nevertheless, I would like to emphasize, to focus my attention in the educational aspect of this talk. I would like to speak about clinical trial using mesenchymal stem cell in wound healing. And the first question is, why use mesenchymal stem cell in wound healing? Well, we are a team of surgeons that are very concerned with the main problem in surgery, that is wound healing. Among the potential application of stem cell, our interest, our focus was soft tissue repair, the properties of this kind of cell in order to improve the wound healing. The surgery, the surgery of today is performed due to in the past 2 centuries was 3 great revolutions. The revolution of anesthesia, that permit operate the procedure without pain, the revolution of antisepsia, that permit that avoid infection, and the revolution of the hemostasia, that permit the surgeon work without bleeding. But we can say that the majority of the failure of the surgeon today is due to a failure in the healing. We can say that the more important pending revolution today for surgeon is the healing, and healing is a really cell-based process. And then, in the beginning of our experiment, in the beginning of this century, we work with the hypothesis that a stem cell supplement might improve healing. And the idea was, if we can put more cell in the critical area, in the surgical critical area, we can achieve better results. And then most of research team work about the property of this cell. We know that this kind of cell work using 2 different actions. The first is that produce a regulator of inflammation, and the other hand had an important immunomodulatory effect. And then these 2 mechanisms can produce an important improve in the healing. And this is an educational session entitled From Bench to Bedside. And for us, the question is, how can translate this basic knowledge to the clinical set? And the main question is how this stem cell can help to surgery. Among the different possibilities for treat disease using stem cell, our first experiment were focused in the suture. Suture is the main or a real problem for surgery. From the beginning of the surgery, there is an important problem, that is the gap between the needle of the suture and the strength. There is a gap, a caliper gap, and needle is in the majority of the cases more thick than the strength. And this is a big problem because the hole that produces the needle is higher than the strand. And we think that we can put cell in this gap in order to achieve a better healing in the point of the stitches. And then our first experiment was using stem cell, mesenchymal stem cell, in order to cover all of our thread, our suture, using mesenchymal stem cell. Well, we observed that this cell coming to the suture and cover all of the surface of this suture, and with this special kind of suture, we designed experiment directed to know if this biosuture can improve the healing of colonic anastomosis. We designed an experiment and we observed that this kind of bioshooter, is named bioshooter, have a similar fit than the normal shooter, and the other hand is a similar management. For Asarion, if you cover of the shooter with cell is similar than the normal shooter. And then with this shooter covered by mesenchymal stem cell, we perform anastomosis in rat. First, we cut the colon, as you can observe in the slide. Later, we perform a classical colonic anastomosis. In the postoperatory time, we sacrifice the animal and study the resistance of this anastomosis, and we can observe that when we use shooter covered by mesenchymal stem cell, we achieve better resistance, and more important for us, there is less adherence. Or less adherence is very important because we can achieve a fantastic resistance without an increase of adherence. And then we publish this result, but the main problem is how to translate this finding to the clinical setting. It's possible to perform anastomosis using stem cell in patients. Another question is how these cells are working in order to improve this anastomosis. And after histology study, we observed that there is difference between the shooter in the control group and in the cell. And we, summarizing or in a scheme, we can observe that in normal condition, this is the classical evolution of the resistance of the histological event after an anastomosis. We observe that macrophages coming to the shooter later than fourth day. But when we use cell, when we cover our shooter with cell, we observe that this phenomenon is very different. Macrophages coming to the anastomosis in the first day. We can say that the acute inflammation is very short, and this is more important, better important for surgeon because this is the critical days of the anastomosis. We can change the speed of the phenomena using stem cell. We think we can translate this knowledge to the clinical setting, and we think that the possibility of use this special shooter in critical anastomosis, for example, colorectal or coloanal or esophagus anastomosis, and also in tracheal anastomosis, nevertheless, is so difficult to design experiment or clinical trial in the clinical setting. Regulatory affairs to the day make it possible to translate this knowledge to my operation room. Nevertheless, we have some experience using a compassionate use. For example, this case is a patient who had a tracheomediastinal fistula due to radiotherapy because this patient had a lung carcinoma, and we can treat this hole in the carina using stem cell, and we achieve a better result. Nevertheless, in the case of the shooter, it's so difficult to translate due to there is a biomaterial and cells, and the regulatory affair is really, really complex. But in what area there is a real clinical trial using mesenchymal stem cell? The area more explored by clinical stem cell clinical trial using stem cell are the gut, the digestive tract, and specifically in digestive tract we can observe a lot of clinical trial in order to treat fistula. Fistula, why using stem cell in fistula? Because fistula is a real problem, an unmet real problem, and the fistula, the perianal fistula, is a dilemma. In this way, we can say that if we are very, very aggressive treating a perianal fistula, patient became incontinent, and this is a very worse problem, so difficult to resolve. If you are soft and you perform a little operation in order to treat fistula, recurrence is very, very frequent. And we can say that surgeon, we are not happy with the result. Using classical surgery, or in the case of Crohn's disease, using anti-TNF or different treatment. We are not happy. The result is a disaster, what we can say. Specifically, in the patient who had Crohn's disease, because patient who had Crohn's disease had an important problem of wound healing. For us, this is the target of our current investigation research now. And then the next step is our target is to treat fistula in patients who had healing problem, for example, Crohn's disease problem. What is the best source? What is the best source in the clinical setting in order to treat this patient? Well, most of the college are using, from the beginning of this experiment, are using bone marrow, mesenchymal stem cell from bone marrow. Nevertheless, we found that adipose-derived stem cell, mesenchymal stem cell, show important advantage that very efficacy is very in the clinical setting are very, very suitable. The procedure in order to obtain this cert is very, very easy, because we do not need run stimulation on bone marrow, and we can use only a little liposuction using local anesthesia, and we can harvest a high quantity of these cells. The scheme of our procedure is very easy, because we perform a liposuction, after that an isolation of this of mesenchymal stem cell, and then cryopreservation or cell expansion, and then we are ready to implant in the indicated case. But the more important is that we need to perform a clinical trial program, a complete clinical trial program that includes preclinical tests, phase 1, phase 2, phase 3. It's very, very important to complete the whole process. The more important step is the more complex, is to achieve a phase 3 clinical trial, because you need a high amount of patients and high quantity of the rule for phase 3 clinical trial are very, very rigorous. Well, with this idea, in the beginning of this century, in 2002, we start our pipeline, and this is our complete pipeline, and you can observe that maintain an important preclinical activity in order to translate knowledge from preclinical to the clinical trial process. We perform a proof of concept, a phase 1, phase 2, and now we are working in phase 3 clinical trial. Well, the history is very, very easy. We start in 2002 with the proof of concept. Was a young woman who had a rectovaginal fistula, treated previously for several surgeons, and you can observe the scar, the different scar, the previous failed operation. In this young patient, we perform a little liposuction in the periumbilical area. We extract cell, and we put the cell in the internal opening of the fistula. In the key point for treat fistula, we achieve good result, and we achieve a healing of this area. After this proof of concept, we design a phase 1 clinical trial. The phase 1 clinical trial was in five patients who had 8 fistulas. We achieved success in 75%. But this is not important in a phase 1 clinical trial. A phase 1 clinical trial is directed to know factibility and directed to know safety, not not efficacy, because there is not a blinded study, it is not a randomized study. And from this phase 1 clinical trial, we learned that no severe adverse event appeared using this kind of cell, and during a long follow-up, we do not detect tumorogenic events. With the credit of this phase 1 clinical trial, we can design a phase 2 clinical trial. The phase 2 clinical trial was directed to treat patients who had complex perianal fistula and was a very rigorous clinical trial. It's a multi-center, randomized, controlled, and a very complex clinical trial. And then we treat 50 patients who were randomized into 2R, 25 patients was to the experimental treatment, and 25 patients was to the control group. The control group, we put only fibrin glue, and the experimental group we use fibrin glue plus cell, mesenchymal stem cell. The procedure, the surgical procedure, will be very easy because we do not remove the tract. The normal, the classical surgery to treat the fistula need removal the tract of the fistula. And when we are removing this tract, normally we can produce incontinence. But in this kind of procedure, we do not remove the tract, only put cell. And then we do not can produce, we can't produce incontinence. It's a very advantage of these new techniques in order to treat perianal fistula. Well, this is probably for surgeon, but it's important to remark that we put the majority of the cell in the area. This is a scan of the fistula, that a fistula had an internal opening that is in the anus, an external opening in the perianal skin, and one tract. Well, the more important point and the more important key is the internal opening, because infection coming through the internal opening to the external opening. And if we can heal the internal opening, all of the fistula remain achieve a complete healing. And then we put the majority of the cell in the area of the internal opening. Well, results from this study show also an excellent safety profile, and the main result you can observe in this slide. The main result is that we achieved 71% in all cases, 71% of healing against 16% of healing when we use only the placebo, near to placebo fibrin glue. And this number repeat in all population. Patients who had Crohn, 71 against 16, patient without Crohn, and patient who had a very complex fistula. It's a very constant number. We can say in our published in our paper that we achieve success in 70% of the cases. After this experiment conducted in Madrid, other team has repeated this experiment, and for example, college from Italy repeat our experiment and also achieve 70% of good result. Other college from Korea repeat exactly our design and achieve 82%. But it's important to remark that this is a phase 2 clinical trial. As the more important key is not the phase 2, it's the phase 3. Due to you need an important number of patients, and the rule for this special phase 3 clinical trial are very rigorous. And then after this phase 2 clinical trial, we design, we develop a phase 3 clinical trial and control the control of efficacy were performed 24 weeks after injection of the cell. And result from the phase 3 clinical trial show no differences no statistical difference between when we use cell, when we use fibrin glue, and when we use fibrin glue plus mass cell. This is a frustrating result, but when we study deeply in this result, we can observe that the main important result is that fibrin glue show very, very good result. Fibrin glue in the previous study do not show more than 30% of healing. And then what is the problem? When we study the result, we observe that some group, for example, our team from La Paz University Hospital achieved better result than the other colleagues, and you can observe that we achieve near more than 80% of healing of the fistula, and the fibrin glue appear in normal number. Why? What is this? The question? Why in one hospital appear excellent result and in the other hospital do not appear the result? The difference, we observe that my colleagues from other hospitals were including patients with a low complexity fistula. Very, very different than our kind of fistula in La Paz University Hospital, because La Paz University Hospital is a reference center for patients who had complex fistula. And there is significant difference between patients treated in La Paz University Hospital and patients treated in other hospitals. And with this idea, we can explain very, very well that fibrin glue was in La Paz University Hospital in canonic number, and very different than the other colleagues that achieve healing, because due to that the fistula treated by my colleagues are very, very easy, very, very simple. But how can I explain that La Paz University Hospital achieved more than 80% in the worst scenario, in the case of the more complex fistula? It's so difficult to explain, but we perform a technical survey with my colleagues. We have surprises because we detect a large number of mistakes when my colleagues are using cell. We are pioneers in the use of the cell, and my environment are ready to use cells, but my colleagues use cell, including mixing with peroxide, for example. After that, we can say that we have learned that clinical trial, when we use cell therapy, are very different than the other clinical trial, and need a special training, not only of the surgeon or the whole environment where cells are using. We can say that this is a very, very different drug, a very, very different medicament. This is a real living medicament and need a special treatment in the area, in the environment of clinical trial. This idea can be observed also when we perform long-term outcome efficacy in patients about fistula close. We can observe that years later, in the case on the group of the R that cells were used, we can observe that a recruitment and spontaneous recruitment of healing. This is impossible when we use fibrin glue. This is the idea that this cell remain working in the fistula area after many times after injection. We have published this result, but to the date there is not a statistical significance. But we continue in the follow-up of this patient. Well, in spite of this, capital venture lost the interest in this therapy due to if only work in La Paz University Hospital is not a business for us, and then we stopped the support this kind of therapy. But we tweak sorry, excuse me. We stopped another phase 3 clinical trial. We stopped this phase 3 clinical trial due to the sponsor lost the interest in this way. I'm going to say that this is a normal process when a new technology appears. It's named as Garnet cure. After a new technology, everything think about the flat expectation, but after that there is a frustration because probably it's not so easy that I think the beginning of the procedure. Well, we change to a new modality of treated fistulas using stem cell. We change to the autologous use to the allergenic use. And we change because several experiments show that this kind of cells are really a privileged immune cells because these cells show a lack of major histocompatibility complex class 2 and show a low express of the class 1. And then we design again phase 1, phase 2 clinical trial in order to test the efficacy of this allergenic stem cell. It's cell from bank, it's not autologous cell, it's cell from bank, from donor. And then we start this phase 2 clinical trial and we observe similar results. Similar result, we achieve near to 60% of healing in this pivotal phase 1, phase 2 clinical trial. But in my opinion, the more important for us has been the result that we've observed in the second allergenic phase 1, phase 2 clinical trial that are directed to treat patients who had rectovaginal fistula. Rectovaginal fistula is very, very difficult to treat and need a reconstruction of this area. You can observe this is the anus, this is vagina, and you can observe the defect, the gap that permit that feces coming to the vagina. And we can't treat this only putting cell in the area because the gap is bigger and we need to perform some kind of operation. We change our idea. We think, well, we want to perform classical surgery for reconstruction of the rectovaginal wall. I know that this technique is failed in the majority of the cases, but if I put cell under my suture, we can achieve probably better result. And then we perform this procedure. We perform first a surgical reconstruction of this wall, and in the end of the operation, we put the cell like that we were in the suture, and put the cell in order to support the surgery. And then, with this technique, we have achieved near to 60% of complete healing of these cases, of these very, very special cases, because this woman, the only solution for this woman is a ostomy, is a colostomy or ileostomy. And in these cases, 60% of the patients do not need to perform an ostomy. And then we can say that when we perform two injection and two surgical approach of this rectovaginal wall, we can achieve a complete cure in near to 60% of the cases. The question is, why not repeat the doses? In the patients that do not achieve a complete healing, why do not repeat the doses? But this is not our suggestion for regulatory agency, but because there is not incontinence risks. On the other hand, this procedure is is not a painful procedure. But we are waiting for permission from regulatory agency in order to treat, to put new injection, new cell, new procedure in this special case of the patient. And then with the learning in this, with the different knowledge acquired in this pipeline, we are working, we are involved in 5 clinical trials in order to focus, to find the best way to treat this kind of patient. And well, what happened in world? To the date, there is 10 clinical trials published in order to treat fistula in patients who had Crohn, in patients without Crohn. And there is in the clinical trial, there is 13 clinical trial script, and now it's ongoing. The more important of this clinical trial is that there are 5 studies in phase 3 clinical trial. This is very, very important. And there is 3 studies recruiting patients to the date. Recruiting patients, currently recruiting patients. And these 3 studies is very, very different because so 3 different strategies and use 2 different cell sources. And then the more the best, I think that the study from Osiris Therapeutical was the pioneer of this phase 3 clinical trial. And the product are human mesenchymal stem cell from bone marrow used intravenous, and they use a lot of cells, 1,200 million of cells. It's a very different strategy than our strategy. Celerics antigenics are using adipose-derived stem cell in allergenic mode, and in these cases are using intralesional cell, and you can observe very, very low doses of cell, 120 million of cells. Tercell, this is a network from Spain in cell therapy. We are involved, and we are using as normal adipose-derived stem cell in an intralesional way, and the doses range from 20 and 120 million cells. Summarizing, 3 studies current working in the phase 3 clinical trial, and 3 different strategies and 2 different sources of cells. This is the last slide. We can say today that mesenchymal stem cell for fistula treatment is the first application of the cell therapy that had been complete a whole course of clinical trial and a real way from to the bench to the bedside. We are proud that Europe is the leader in this kind of study. And then thank you very much for your attention, and thank you very much for my team of research. Thank you. 5 minutes for question from the floor. Thank you very much. The second speaker is Odi. Sorry, a question from the floor.
How different are these cells? I mean, when you isolate them from different patients and you culture them, how different are they, and does that influence the outcome in the clinics? I mean, the expansion and so on?
You are speaking about allergenic use.
Yes, I mean, is every patient the same in terms of isolating the cells, and how well can you characterize this cell product, and how does it influence the outcome?
Yes, we found important difference between the cell and the patient. In some patients, cell the the culture of the cell is very efficient, and another patient is not efficient. And there is a clinical picture, the clinical characteristics that are related with the culture or no culture, or the adequate culture or better culture than another. But it's not a clear difference. But in some cases, it's so difficult to culture cell from some patient. I don't know why. Odi?
One question. Very nice presentation. Congratulations. Then one question. What are the difference regarding the markers, the morphology of the adipose mesenchymal cell and the real mesenchymal cell?
You mean that the real mesenchymal stem cell from bone marrow, for example? It's a nice question, but the difference, there is a discussion about if mesenchymal stem cell from bone marrow or from fat are the same cell or different cell, as you know, probably. Many authors think that it's impossible to observe difference between bone marrow mesenchymal stem cell and mesenchymal stem cell from fat. But there is another author that saw that there is some different marker, but it's not has not been well demonstrated, and there is it's not clear this aspect.
And it's a dispute in this
Yes.
area, and are very solid evidence, then it's a difference. But in the case then you are focused in the therapeutic effect, doesn't matter.
Yes. Well, I'm sorry, I'm not a biologist. My colleagues say that many authors do not found this difference and are discussing this aspect. But for my practice, for clinical practice, I think that probably is better cell from fat, because fat is the organ or the area of the tissue more programmed for healing, because the majority of aggression in the human, in the mammalian, is in the skin, and under the skin there is the fat. And probably there is a teleological program better designed for achieve healing in the case of the fat than the bone marrow. Is my opinion from a clinical point of view. Thank you very much. Nice question.